little introduction, he has done an amazing work for organizing the AIOC2023. He is the professor and HOD of Amrita Institute of Medical Sciences here at Kochi, and he will be talking on initiation into clinical learning. Dr. Gopal Pillai.
He is one of the senior most professor in Amrita and a fantastic teacher. Apart from being a great dynamic surgeon, he is also a great teacher. So I request Dr. Gopal Pillai, Dr. Gopal Pillai, to please go ahead with his talk on initiation into the clinical learning.
In a fellowship program, we require clinical learning is the most important thing.
Timer.
So, in clinical learning, the person should basically look at analyzing the symptomatology, adding symptoms to symptoms. Like if somebody is coming with a decrease of vision, you will be thinking about one differential diagnosis versus if the patient has decrease of vision with pain, there will be another set of differential diagnosis. And with something else, there will be another. So that is the adding symptoms to symptoms and sign to sign or sign to symptoms and getting your differentials in different age groups is also important. So forming a differential diagnosis and defining the leading and narrowing the differential diagnosis with tailored investigations. This is what has to be done. Finally, the business of medicine would warrant more and more blanket, shotgun investigations. But what is actually required would be tailored investigations after narrowing down the differential diagnosis based on clinical learning. And finally, management and analysis. These are the things we have encompassed. It is the most important part of learning. It is important that the fellow or the postgraduate who is joining the course knows quite well about this. So you have to first come to a differential diagnosis and then do a final diagnosis. Decide on the management plans and risks and benefits about each, and finally take home the best personalized plan. The purpose is to have a proper differential diagnosis and diagnosis investigations. Cost effectiveness is something that we have to look at in our context of our country. Improving the clinical sense, like maybe you can negate certain diagnoses, maybe you can support certain diagnoses. So all this is possible only if you have a proper clinical sense. And planning a management algorithm. See, our country will have a management algorithm which is possible. In some countries which are insurance driven, the insurance decides the management algorithm and you cannot change. So in our mind, the personalized medicine can go into the patient if our clinical learning is good enough. And always we have to do this risk-benefit analysis in our minds. So the principles are, what are we looking for? So that is what we need at the end of the clinical learning, which is we are looking for the final diagnosis or final management options. So epidemiology is a key factor. If one 20-year-old is sitting in front of my OPD versus an 80-year-old is sitting in front of my OPD, I should be thinking differential diagnosis in my differential diagnosis in my mind, and that thought process has to be going. Symptom basically gives us the acute pathology, what is happening inside that, and science will give us localization. So to plan tailored investigation, support, confirm, or negate diagnosis, we require tailored investigations. So there has to be an active push back from the fellow or the postgraduate to have active engagement and participation. Here is one thing in which, unless you understand it fully, you will not be able to take it to the next level. So if you do not understand, it is up to the fellow or the PG to ask his mentor. So encouraging students to actively participate in patient care activities and asking questions, because everybody may have different thought processes, different points of views, different perceptions. So they have to actively participate and put their point of view and not say that, what the master says is the only final word. There is nothing like that. There are 100 ways to skin the cat. All of us know it. And we need those children to actually participate in that. Hands-on experience, enhanced learning skill, and a learner-centered approach is what is important. So, many places in postgraduate, when the numbers are less, there are a lot of issues pertaining that. You always have to provide students the opportunities to engage in the real-world patient-based scenarios. But sometimes it may be difficult because some patients may come for a particular doctor with an appointment. But it's important that the patients be provided with such opportunities and have them come up with a differential diagnosis after the workup and probably their thought processes, which could be refined further by a mentor. And also, always during your actions, foster empathy, cultural competence, and effective communication skills. And these are very, very important, more important even than the diagnosis nowadays. And that is what is required. And mentorship should be, we have to be supportive, and there has to be trust. And mutual trust is very, very important, especially when you are mentoring for surgery, etc. Like you have to have that trust. The fellow should stop where he feels that further going on will cause some problems. That has to be there. That trust has to be earned. Offer guidance and mentorship, and facilitate the regular feedbacks. Feedbacks are very important. Positive, constructive feedbacks, as well as negative feedbacks, which will help them, get over it, is very important. Reflective practice in self-assessment. It encourages students to reflect on their own clinical experience, how they perceive their own learning, their own strengths and weaknesses, and how they can improve. Critical thinking and self-assessment tools are very important. Theory is a very broad understanding, and practice is a fine art where bringing the theory to the patient in question, and that is where clinical learning comes. Developing clinical skills, critical thinking, and decision-making abilities are very important. It's a slow and steady process. It keeps on increasing. Even we will be improving in our own skills and judgments over a period of time further also. Perseverance is an important thing there, and always you have to have clinical exams to get that. So the key principles are active engagement, authentic patient care experiences, guidance, and reflective practice, as I said. So preparing these students, first of all, we have to give them an orientation, reviewing the patient care protocols, safety and infection, and equipment should be familiarized before they get in. There are some challenges. There is some workload. There will be a lot of patients to be seen in the OPD. You can't give them 15 or 20 minutes to form their differential diagnosis. Time constraints will be there. Limited exposure to certain clinical scenarios which are very rare, and sometimes emotional stress, all those problems will come in. So we have to support them, mentor them. There has to be peer support networks as well, and educational material should be done. To conclude, the most important thing in a fellowship program is to facilitate the learning process, the clinical learning process, and overall the patient as a whole has to be looked at, and tailored investigations and not shotgun approach. There are hard and soft clinical markers. You should differentiate between them, and they will form time to form judgments. Thank you very much.
Thank you, Dr. Gopal. It was a very crisp and nice presentation. My question to Dr. Uni. Dr. Uni, you are having a big private institution, and as we all know, that since it's a training center also, the patients tag us like a teaching institution. So somehow, how do you handle these private patients? If everything goes well, it's okay, because sometimes they double cross-check whether are you operating, they cross-check with the doctors or with the clinicians or the consultants. If everything goes well, it's okay. If something goes wrong, then I have seen certain examples where they go in for the negligence, proving the court case and all of it. So how do you try to balance between training the fellows, make them see this variety of cases, and at the same time also making them feel that, okay, the consultant is fully there with you? How do you try to make this balance?
So what I do is probably a reflection from the place I learned my year. So what we do is that again, most of our patients are paid patients. So our fellows get to start the workup, see the workup. The patient always has the assurance that they will see a consultant. It never goes from a fellow level. So after the workup, it goes from a consultant level, and then they come to the consultant room to see the patient after we see and we put our points in also. Regarding surgery, I make it a point to always be inside the room when the fellow starts the surgery so that I can take over or talk to the patient if required. And the fellow gets to start only when the drink is over the eye, essentially. So that is one of the most important features of not being able to recognize, and there is a strict no talk policy inside the theatre. So these are the couple of ways we manage it.
One big question to Dr. Pramod sir. There is a software which is called as iGen software, which is for the ROP kind of thing. It was developed in Canada, and during the COVID times they have developed this software, like where is zone 1, which is zone 3, and they have to undergo these tests, and then it gives you the marks also. So which one you have pointed out right, which one you have pointed out left. So what is the part of the simulation part of the training in the fellowship program? Does it make a difference for the fellows before they see, especially the ROP babies?
Yeah, as far as surgical skills are concerned, examination, also you talk about ROP, probably that will cut down the learning curve, I will say, shorten the learning curve most time because particularly new simulations are there quite good. Yeah, so definitely like pilots, you can't say I will try on a flight. Simulation is necessary. Similarly, ROP visit maybe practical issue is parents are sitting there, most of them are like emotionally involved, and then somebody maybe is crying, and then trainee is examining and struggling, and you come back again and want to examine. They don't want that most of the time. As a parent, I also don't like, and that's the role of simulator comes. I think definitely it helps to shorten it. But what so that is the one. But most of the time coming back in these babies when we take for a laser in the OP, that is the time students can have a look at it. But yes, the main purpose is to shorten that curve. But ultimately, finally, whatever simulator is different. When you specifically talk about ROP, how to handle the baby. You have to get over your own that emotional feeling that handling those entire baby fits in your path. Like, so that eventually you have to practice. But yes, because you've already gone through startup simulation and work out on that. Like same thing was you have done enough PRP using indirect laser photocoagulation. That startup back to the simulation when you want to do laser for ROP where you can't see patient is not cooperating. You have to do it. It's one of that. But definitely there is a role for simulators in our practice. But that is not everything. Ultimately it's like
any quick comments from Mahesh sir on Dr. Gopal's presentation?
Nothing, very nice presentation. I would agree with what Pramod said, like simulation is one. It lays the groundwork, but then like subsequently examining the patient or examining our child is totally different. So they still need that experience on it.
So Dr. Gopal, one last question. Do you protocolize your training schedule like they have to first see the OPD for first 3 months and then enter into the OT and then start the vitrectomy after 6 months? Do you follow the protocolization?
Fellows are post-MS. So their protocolization will be a little different. I would not want them to just sit in the OPD. Then I would ask them to come to the theatre, definitely. But giving surgical steps and all would be a little slowly. I mean, one step at a time, like that. Once you're comfortable with one, then we'll move on. By the time we'll develop that trust as to whether he will overdo his steps or whether he will be fine with whatever he knows. So then that is a slow thing. Clinical diagnosis, laser, angiogram, all those things are also stepwise. Yeah. So I can think that there is a protocol involved.
Just want to add one more thing was Kunni was talking about. What I do, tell fellows, when they can examine the patient, then I want them to write their plan. Actually, just concise, summarize the entire history, whatever they are going through, 100, 200 pages, some patient carry all those things. And it's 8, 9 sentences, you just narrate, and I tell them as if you present case to me. And write down their diagnosis, their plan of action. So then, but then discussion happens not in front of the patient. We do everything, patient walks out, I correct that one. So, but I know his thought process. So when you write something, your thought process should reflect to that, how exactly so somebody else reads that or whatever is written. We do correct in the So I close up the file only when I do correction. But I insist on they should write. Rather than they just see patient draw something and then you take over. And no nonsense talk in front of patient. Whatever questions, all those things, once patient is out, then we discuss.
Exactly. Very true. Very important. Because that patient is going to tell others also the same thing what has happened in the OPD. Thank you very much, Dr. Gopal.
I'll try to arrange something for you.
I think
They get some documents.
You can just exchange for some time.
It's okay. We'll finish.